I just wanted to say that our previous talkers, we didn't collaborate or corroborate. We all made our lectures individually. So some of the stuff I'm going to be talking about is about how I look at nutritional supplementation and how I look at what the future for treating dry macular degeneration patients are. So it's not contradictory in terms of you should the fact that we have a FDA and we do these studies. The way I look at these studies, like the ARED study, I was one of my dad's partners, who's now in Boston. Her name is Joanna Setting, and she was the first person who helped formulate the AREDS vitamin formulation. Okay, and Dr. Kim discussed, for example, the retinopathy of prematurity. Well, when I was back in the 90s, you know, those papers were in '98. Back in the 90s, I worked with Lois Smith at Children's Hospital in Boston. And if you talk to Lois, who was a basic scientist, she's also a clinician but doesn't see many patients, Lois would have told you that light therapy would not work. We were already working on the true mechanism of retinopathy prematurity. And right now, the medicines that we develop, these anti-VEGF therapies that we keep on referring to, they're using it now to treat patients, babies, who have retinopathy of prematurity. Okay? So, what I want to convey to everybody here is that I personally, in my career, have looked at the basic science and tried to predict what would work. I've had a really good track record doing that. First of all, the story for these medicines, the anti-VEGF medicines, was really a story told by one of my dad's contemporaries. Not contemporary, no, actually he was ahead of my dad, actually. Back in 1948. The story of VEGF, which is the weed grower, right, was postulated by his name was Norman Ashton, back in 1948. And it took 40 years to find what this postulation. The story was that an eye would produce a factor that would produce blood vessels that grew in blinded people, in macular degeneration, and in diabetic retinopathy. Now, it was not until 1992 that science caught up to that story and actually identified that that factor, they used to call it factor X. Everything was factor X, Mr. X, factor X, etc., right? But the story eventually came up, and we found factor X in a laboratory in Boston. It was, I remember clearly, it was Tony Adamus, who was at that time just a trainee, and he was working in lab. He was in the 5th floor of Mass Eye, which was at Harvard, and we were talking, and he said, "You know, Mike, I think I found the factor that produces diabetic retinopathy," and you know, I was just out of med school at that time, but because these were dinner conversations with my dad, I said, "You did," and then the rest is history. That's why we were ahead of the curve. The medicines that we developed, okay, I was the first person to actually administer an anti-VEGF therapy in a model of the eye. Before, they were looking at it for cancer. Okay? Now, you know, we're injecting that drug last year, in 2009. There were 1 million injections of this drug. 1 million. The time it took to make that idea into a reality was from 1993, 94 to 2005 or 2004. It's a long time. There are a lot of patients that I saw in that interim of time who lost their vision and cannot be retrieved. Now, the reason I'm talking about what I'm talking about now, because I think it's the future of how we're going to treat macular degeneration. It'll take at least 25 years for me to get the information that's required, for example, for that AREDS 2 study. 20 years. I know that for a fact, because Dr. Seddon, who was, again, a partner of my dad's, she was talking about this regimen, the AREDS formulation, back in 1980, right? And then the study came out with a result in 2002. That's a long time. The study we're involved in now is called the AREDS2 study, looking at these things. Our site at the Center for Retina Macular Disease, we're the #3 recruiter in the country for this study. We have over 100 patients involved, and some of the people in this room may be involved in that study. But we won't find out information from that for another 5 years, 6 years. And also, it's not asking the right question. It's answering the question right now, which was asked 15 years ago. Okay? So, some of the stuff I'm going to be talking about now is not going to be studied for another 20 years. But it fulfills a story. All the evidence, the basic science, accumulated with some of the clinical science, all point to the utilization of this technology now, even though you don't have the concrete evidence that you would want from evidence-based medicine. So I just want to take, this is sort of a start because I'm going to talk about things and I'm going to be recommending things based on that, not on clinical-based evidence, which I believe in. My mentor, my chairman at the University of Pennsylvania when I was a professor there, where I met Dr. Maddow, who is going to be one of our speakers. He was the king of clinical-based medicine. And I learned very well from him that, you know, you have to study these things in a very rigid fashion, and I respect that. But I'm going to tell you that there are other ways to look at these molecules, okay? Now, I'm going to start out with analysis of prevention. Okay, we know that there are risk factors that cause macular degeneration. Smoking, genetics. This is the picture that I told you about, the body mass index, and I think I look like the second from the last of that side. And I told Dr. Seddon just this last weekend, when she showed this is her slide actually, that why the heck did you copy, why did you get my shadow? You know, it's embarrassing, you know. We know that you know, fish intake is very good. Exercise, you know, Dr. Dupree was talking about exercise. Everything's very good. The green leafy vegetables. But then what I want to talk about is also supplementation, because like the data that was put out there by Dr. Kim, supplementation can be helpful in preventing, and theoretically it can also be helpful in doing other things. Now, the ounce of prevention is really worth a pound of cure, because the pound of cure is, yes, I did help develop these injections, but it's not a one-shot deal, okay? If I diagnose you with wet AMD, the chances of you having to get injections every 4 weeks, over and over again to preserve your vision, is very close to 90%, okay? Now, there are some people who can escape and maybe get a few injections, but I see a lot of people in this room who I've injected a lot, and I won't point them out, okay? Don't worry, I won't embarrass you, but they're maintaining their vision. Now, what's good is that I know that if I hadn't caught them in time and started injecting them, they would be legally blind. Why? Because for 40 years, we watched people go blind. That's all we could do. If you saw my dad back in the 80s or 90s, and he diagnosed you with macular degeneration, he would say, I'm sorry, but I'll see you in 2 years, and knowing full well in his head that in 2 years you'll be legally blind. Right? Now, instead, what we tell you, when you're in front of us, a retina specialist, is that we can preserve your vision, but you gotta get injections over and over and over again. So, yes, we can preserve your vision, but the pound of cure is really a pound of cure. So it's better to prevent it, right? And do everything in our power to try to prevent it. So I'm going to go over how we can do that with our current technology. Now, you know technology is moving at such a rapid pace that what I tell you now may not be the same thing I tell you in a year if we do one of these things again. But right now, we can identify risk, and we can catch the disease early with the technology that we're actually doing, that we have available to us at this moment. We also have nutritional supplementation, which has varying degrees of clinical evidence. But the basic science evidence is overwhelming. And that's sort of why we're going to start out talking about this, even though we're not going to necessarily have the clinical evidence that would be published in the New England Journal of Medicine. Now, we know that AMD is mostly genetic. I gave you this figure before. If one of your parents is affected, then you have a 50% chance of getting the disease. If your father and mother are not affected, you still have a 12% chance of getting the disease. So we know that there's a genetic predisposition to this disease. Well, as of 2004, well, actually it says 2005 when they were published, but these were being presented in meetings in 2004, we discovered the major genetic changes. I should say, I don't want to say mutation because scientifically I was corrected about that by several geneticists. But these are variations in genes that predispose a patient to developing macular degeneration. And I'll show you in just a few slides, it also can predict your progression. If you have the disease and you have these genes, it can predict how bad you will get. That's pretty powerful. Think about that. Now, this is one of the first papers that really demonstrated that they found several genes, several variations in genetics. I have to really correct myself because I keep on using this, and then I talk in front of doctors, they always correct me, especially basic scientists. Several variations. If you have, there are now probably around 14 variations in your genetics that predispose you to macular degeneration. Dr. Seddon, again, a partner of my dad's up in Boston, she found that if you have 3 of these variations, your risk of developing macular degeneration is 285 times those who don't have those variations. That's a lot, don't you think? So let's say they check your gene and you have 3 of these. Your chances are 285 times that you will suffer from macular degeneration, the blinding form. Okay? Now, if you don't have any of these polymorphisms or variations, then it's less than 1%. That's pretty powerful stuff. You can utilize that. This is the paper. Again, JAMA is a very well-known journal, and actually, Dr. Seddon used the same data set. Remember that vitamin study? There were 3,000 patients in that vitamin study. And she followed these patients, well, it was followed as part of the protocol because she helped design the study for the AREDS-1 study. And follow them and stratify these patients, those who progressed, meaning they became advanced, and those who didn't progress, right? So there were like 1,400 patients who didn't progress in 6.3 years. But there were like 200 and some who did progress. And she prospectively collected the DNA. So prospective means that they thought about this beforehand, not after the fact. And what she demonstrated was that if you had 3 of these polymorphisms or variations, plus you had the drusen, the grade that Dr. Kim had mentioned before, and you were also a smoker, it could actually attribute 81% of the population. Well, I'll try to explain this in a simple way. It's like the chances that you will get or progress the disease is 81%, okay? Based on just these findings. Now, what does that mean necessarily? Well, you know, we take a lot of tests. How many people here go to the doctor's office, not an eye doctor's office, but an internist's office, and get their blood pressure checked? How many people get their cholesterol checked? Okay? The doctor's office, exactly right.